A very good evening, everyone, and a very warm welcome to our webinar on a topic that often goes under-recognized but profoundly impacts millions of lives, neuropathy and diabetes. I am Anja Jose, part of the medical team at Macleods, and I'll be your host through today's session, which is focused on raising awareness, deepening understanding, and empowering better care for those at risk or living with this complication. Diabetic neuropathy affects nearly 50% of people with diabetes during their lifetime, yet it often goes undiagnosed until it causes significant pain, numbness, or even disability. So today, we'll discuss the early warning signs and highlight how timely intervention can help prevent progression and improve quality of life for such patients. So let's come together to shed light on the silent complication and work towards a future where awareness leads to action and action leads to better outcomes. So we are thrilled to have two distinguished experts joining us today to shed light on this condition from their unique perspectives. So please join me in welcoming our very first speaker for today's webinar, Dr. K.M. Prasanna Kumar. Shall we have the next slides for Dr. K.M. Prasanna Kumar, sir? So, Sir is a towering figure in the field of endocrinology and diabetes. Sir is a leading endocrinologist at the Center for Diabetes and Endocrine Care, Bengaluru, a former senior professor and head at the MS Ramaya Medical College. Sir has held numerous esteemed positions, including the past president of RSSDI, the ESI, and the Indian Thyroid Society. With over 200 publications and 30 orations, he continues to contribute through research, clinical practice, and the healthcare outreach. We are truly privileged to have Dr. Prasanna sir with us today to share his insights on diabetic neuropathy from an endocrine perspective. Our next speaker brings a powerful combination of clinical expertise and frontline experience in neurological care, particularly in stroke and nerve disorders. So please join me in welcoming Dr. Sadanand De, Senior Consultant Neurologist and Stroke Specialist at the Apollo Multispeciality Hospital, Kolkata. Sir is a recipient of the World Stroke Organization's Young Neurologist Award in 2014 and the ESO Travel Grant 2018. He has led acute stroke management efforts across institutions, including as in charge at the AMRI Mukundapur, and has ensured Apollo Multispeciality Hospital's participation in the rescue registry for the past 6 years. So with expertise in thrombolysis, thrombectomy, and evidence-based neurology, he now shares his insight with us today on the neurological challenges of diabetic neuropathy. So we're delighted to have you with us, sir. So the session would follow. We would have our first speaker, then followed by Dr. Sadanand, and then the Q&A session. So together, let's dive deep into this complication and the necessities of it. So over to you, sir.
Good evening, everybody. Thank you, Dr. Anuja, for the introduction. Can you give me slides here? It's not yet given.
So you can share your slides now.
I still can't get that. It's not showing here.
So would you require help with it?
Can you see my slides?
Not yet, sir, not yet.
Yeah. Now got it. Okay.
Yes.
Can you see my slides now?
Yes, sir, yes.
Yeah. Today, we are talking about diabetic neuropathy. And the topic is stop neuropathy before it starts. And what is the diabetologist perspective in early detection, proper management, and how to avoid the complication. This is the flow of my talk. What is the epidemiology or burden of diabetic neuropathy to the individual or to the society? What are the metabolic mechanisms? How does diabetes cause nerve damage? Who is at risk? Whom to screen? When to screen? Why to screen? And what are the methodologies of screening for diabetic neuropathy? And what is the importance of glycemic control, which is a key strategy to reduce risk of neuropathy? And when to refer a patient to a neurologist or a specialist, and before it escalates so that it may be too late. Most important, empowerment and prevention. That how to prevent diabetic neuropathy in an individual and what are the practical tips as a clinician. And most important aspect of empowerment or prevention is patient education. Without patient education, you cannot achieve preventing diabetic neuropathy. These are the things which we are going to discuss. Now, diabetic peripheral neuropathy is length-dependent peripheral nerve damage arising as a complication of both type 1 and type 2 diabetes up to 50% of the patients. Meaning that longer nerve is affected first. Where is the longest nerve from spine cord that you get? The longest nerve is in the foot. If you see from brain to spine, from spine to the peripheral nerves, if you look at this, foot is the one where you see the longest nerve comes in. Same thing you see in the hands also, from brain to the spine, right up to the hands. That's why it is called as hand and glove, whether it is anesthesia or burning, whatever it is. So the longest nerve is affected first. It starts in the periphery, starts splitting. Diabetic peripheral neuropathy poses a substantial burden on patients who can experience impaired gait, loss of balance, predisposing them to fall and fractures. And most important, neuropathic pain, which is frequently difficult to manage and affects the quality of life. It is very true because we have seen in the last 40 years, diabetic neuropathy is so severe. You have to experience to know what is the problem. I have many patients who have attempted suicide because of diabetes peripheral neuropathy. Don't shrug it off as a minor symptom or anything. Starts as a minor symptoms, numbness, tingling, then itching, burning, lancinating pain, 24 hours pain, sleep is disturbed. To that extent, it can cause a damage. And these are all the problems starting from simple impaired gait to loss of balance, fall, fracture, and even it can lead to ulcer, and ulcer can lead to gangrene also. That is how the simple neuropathy can lead to diabetic ulcer, non-healing ulcer, ultimately necessitating amputation. Please remember, if one limb is amputated, the chance of other limb being amputated in 5 years is 50%. And somebody having amputation one or two, quantity of life is also affected. It is not just quality of life. So 10 to 20% of diabetic patients are concomitantly diagnosed with diabetic peripheral neuropathy. It depends. If you ask the symptoms, do you have tingling, numbness, burning, itching, whatever it is, in your clinic, 1 in 5 will complain of diabetic peripheral neuropathies. Studies analyzing patients with long-standing diabetes report diabetic peripheral neuropathy has a higher prevalence in these patients. It also depends upon the duration. If patient is newly detected, we did a study where we see SINDI, complications in newly detected diabetic. We have seen even at the presentation that peripheral neuropathy was there. Many times, patient complaints of neuropathy, you check blood sugar 200, 300, meaning that 2 to 3% of diabetics are detected because of peripheral neuropathy. Within 5 years, 26% of diabetics develop peripheral neuropathy, and by 10 years, 41%. I have many patients who have 20 years, 30 years, 40 years, 50 years of diabetes. Nearly after 20 years, 80% of patients will have diabetic neuropathy. Meaning, two important things you should remember: longer the duration of diabetes, more chance of peripheral neuropathy. Longer the nerve, more chance of being affected. Longer nerve, longer duration of diabetes is more likely to get diabetes. Literature reports 50 to 66% of diabetes will eventually develop diabetic neuropathy in their lifetime. So as I said, it's not 50, 60%, 80% if we live 20, 30 years. There are patients, I have one type 1 diabetes, 43 years of type 1 diabetes on insulin 4 days, till today has no nephropathy, retinopathy, and peripheral neuritis. Fantastic. So there are patients like that. Why? Good control of diabetes. So the extent and rate of progression depends on several factors, including patient age, number of years they have had diabetes, as I told you, longer duration, and level of blood glucose control. Please remember, one of the key things is hyperglycemia is a cause of diabetes. We'll come to pathogenesis. There are two types of diabetic peripheral neuropathy. One metabolic, when the blood sugar is 300, 400. Controlled diabetes, neuropathy comes down. Second thing is, it is because vasonervosum, the blood supply to the nerve is decreased, aging, uncontrolled diabetes, atherosclerosis, whatever reasons are, that is because of it, and that is difficult that it comes down. Whereas metabolic one, when the blood sugar is high, you get neuropathy. You control diabetes in days and weeks, it disappears. Diabetic sensory motor neuropathy, known as DSPN, is the most common type of diabetes. So diabetic neuropathy can be sensory, motor, or can be both also. Lot of studies have shown that 28% of diabetics have the neuropathy. It depends upon which patient, which age group, which country, what duration you are treating. That's why it can vary 20% to 80%. The exact cause of diabetic neuropathy is still not clear, but three important things are hyperglycemia, dyslipidemia, insulin resistance. Okay, these are the three main etiopathogens. But this alone is not sufficient. What triggers the onset of diabetic neuropathy? Mitochondrial dysfunction. How does it occur? I'll show you. Inflammation, oxidative stress, altered gene transcription and expression. Whether it is microvascular complication, retinopathy, or neuropathy, could be metabolic to a great extent, 70%. But 20-30% can be genetic transcription. Because even in DCCT trial, UKPDS trial, tight control did not prevent 100% of neuropathy, retinopathy, nephropathy, meaning that beyond the metabolic control, there is a gene transcription factor which is responsible, and that may be there. These processes collectively lead to damage in the neurons and glial cells. Remember, the hyperglycemia and dyslipidemia, insulin resistance, damages not only neurons, glial cells also. Certain commonly used medications such as metformin, proton pump inhibitors. A lot of people take proton pump inhibitors. Today you have hundreds of them. And people take for months together, though we say 10, 20 days, they take years together telling I have acidity, I have gas. And both of them contributing to diabetic peripheral neuropathy, because there are a lot of studies. We published a paper a few years back. Patients who are on metformin, 20-30% have B12 deficiency. Patients who are on metformin, diabetic, plus vegetarian, because none of the vegetarian contains B12, are more likely to get B12. They are more likely to get diabetic peripheral neuropathy. So also proton pump inhibitors prevent the absorption of B12. This is the mechanism, simple one, how hyperglycemia, insulin resistance can damage the nerves as such, microvascular disorder you get. Dyslipidemia also contributes to that. So if you look at all the pathways, PKC pathway, polyol pathway, AH pathway, advanced glycosylated resistance, and also hexosamine pathway, PRP pathway, insulin pathway, all these pathways, whether it is age or age, all of them lead to a ligand receptor binding, and then you will get the neuropathy. Then I told you about mitochondrial damage. Oxidative stress damages the mitochondria. Again, the release of these substances can affect the nerves. Inflammation. Why? Monocyte, eosinophil, basophil, neutrophil, all of them secrete many of the enzymes, and these things also are going to damage the nerve. This is how hyperglycemia, dyslipidemia, insulin resistance through the mitochondrial dysfunction and inflammation lead to diabetic neuropathy. To simplify this, how you can see increased blood sugar, whether it is extracellular, gets into intracellular, polyol pathway is affected, sorbitol is increased because of endoplasmic reticular stress and increased ROS, and it leads to DNA damage. Same thing, because of hyperglycemia intracellular, hexosamine pathway, glucosamine 6-phosphatase, UDP, GLC, N1AC is affected, which again in turn cause inflammatory signals, release of free fatty acids. So all these things because of hyperglycemia, insulin resistance, rage, as I told you, or LOX1, TLR4. All these are oxidized to LDL, and then that is how we see dyslipidemia leading to increased LDL, oxidated LDL, and then through this TLR4 pathway or RAGE, you can affect the beta oxidation leading to the nerve damage. So this is how these are the key things you should remember: hyperglycemia and metabolic defects in the polyol hexosamine glycolysis pathway, and also through dyslipidemia, insulin resistance, and inflammatory pathway. All of them lead to apoptosis of the glial cells, neurons. That leads to the peripheral neuropathy. The ADA and the International Working Group of Diabetic Foot, IWGDF, recommend regular examination of people with diabetes to diagnose DPN. Loss of protective sensation using simple standard tests for identification of those at risk for diabetic foot ulcer. Even bedside we can. One simple thing I tell you, every patient of diabetic, every visit, please ask him to take out the footwear. Please ask him to take out socks. Sir, should I take out? It's okay, not necessarily legs. No. Ask him to take out footwear. Sir, shall I remove the socks? Yes, please take down the socks. I want to examine your foot. Look at the pulses. Look at faint touch with a cotton wool, and also use the whatever instruments you have got: vibration sense, touch sensation, pain prick. All these things are there, simple tools. We also have very sophisticated one, but bedside, these are all the things that you can use: tuning fork, a blunt needle, or a cotton. And these are all the things we can see: touch, sense. You can also have a simple one: hot and cold. When you touch it, is it cold or hot? It is cold. These are the things you can write. All patient type 2 screen for diabetes and diagnosis for type 1. Screening should be done begin 5 years post-diagnosis in type 1. Whereas type 2, every visit you have to do and every year you have to do it. If you look at screening, adult 20 to 17 age diabetes type 1, less than 5 years diagnosis, educate and prevent diabetes, neuropathy, optimize control, manage risk factor, consider waiting for 5 years. Patient and provider want initiate screening, then you can see previously screened, yes or not, confirm, stratify, and treat. And unlikely, DSPN, continue annual screening, educate the patient about foot care, good diabetes control, manage risk factors. After 5 years, then you can continue to screen. Type 2 diabetes, you have to screen for multi-phase screening of DSPN, and after diagnosis, previously screened, confirm, stratify, and treat. If not, continue education, good diabetes control. This is how you have to see 20 to 8 years diabetic foot. One more factor you will see: aging. As the aging advances, diabetic and non-diabetic, the peripheral neuropathy worsens. Sensation comes to only elderly people. How to screen? Multi-phase screening. So diabetic sensory motor neuropathy likely, then confirm diagnosis and treat accordingly. And stratify: are they low risk? Treat and review. Moderate risk, treat and review every 3 to 6 months. Mild risk, once a year. Moderate, every 3 to 6 months. High risk, treat, review every 1 to 2, 3 months. Suppose active diabetic foot, urgent referral, individualized multidisciplinary treatment. Who needs? Neurologist, nutritionist, foot surgeon, podiatrist, including psychiatrist. They need individualized review. That is how we had a foot clinic 20 years back where multi-speciality, physicians, diabetologists, endocrinologists, podiatrists. We had a nutritionist, we have a nutrition, and also neurologist. We also had a plastic surgeon. So all 6 of us used to sit. Every diabetic foot was seen, each one, and I will take care of diabetes. Neurologist will take care of neuropathy. Nutritionist will counsel about the good protein diet, and podiatrists will look and clean that, and plastic surgeon if they require, and they will do plastic surgery, or even if they want skin grafting. So like that, it is a multi-pronged attack, multi-speciality. We had a very successful. So 40 years back when I started my practice in a hospital, 9 out of 10 beds were diabetic foot. 10 years later, not a single bed was occupied by this. In the last 16 years, I have not seen an amputation at all. I have not seen a gangrene at all. That is because I have a nurse, a podiatrist, I have a nurse who will do neuropathy test, and we do Doppler regularly. They have a foot surgeon, and we have a podiatrist. We have neurologists to refer. I have not admitted a single patient for amputation or gangrene. Now, most important, as I told you, empowerment of the prevention tips. What does ADA say? Increased awareness of diabetic neuropathy and reinforcing proper foot care can help decrease foot complication. As I told you, how we have made zero amputation, zero gangrenes. It is because of the what we do Doppler studies. We also study nerve conduction studies, educate the patient how to wear foot. Every time they come, podiatrist myself examine that. So ask patient how he feels. Put these things in your clinic. Tingling, sharp, burning feeling sometimes worse at night. Numbness. I cannot feel. I feel like walking on a cotton wool. Decreased ability to temperature. I can't make out hot or cold. Muscle weakness, dry skin, cracked skin. History of foot issues like ulceration, infection. And very simple, all of us have a monofilament. You get two types. One is disposable monofilament, another is permanent one. You can use 10 grams monofilament every visit, touch and see whether he feels it. Check for duration of vibration perception. Please use 125 hertz tuning force, not 400 and all. Please keep 128 hertz hertz of tuning fork, keep cotton, keep a needle, keep a monofilament, take something where you can see reflexes using a knee hammer. So these are all the things which necessary. You can also have a very fancy gadgets if you have a foot clinic and a foot nurse for that. Assess peripheral arterial disease by feel the temperature difference in the feet lower limb, left and right, capillary refill time, check for elevation of pallor, dependent ruber, palpate pedal pulses, dorsalis pedis, posterior tibial. 5% may not have dorsalis pedis, look at posterior tibial. Most important, do not forget to inspect skin for lesions. Look between toes, check condition of nails. In between nose, candidiasis. Very, very common. So spread the fingers, look for candidiasis. If they're there, you put the powder and put cotton. Within 3 weeks, it will heal. Assess intrinsic muscle atrophy, structural deformities such as hammer toe, bunions, inspect condition, fit for of footwear. Ask them to bring the footwear, see it. Many times they wear sandals or chappal, which are useless. Always tell my patient, chappal or anything is only in the house. When you come outside, two things. Wear a socks. Always wear white socks because if you wear a dark one, even if it is dirty, you will not know. If you wear white socks every day, change it or clean it. And then have a shoes which is loose. Don't have tight pointed shoes. One size bigger than that. So wearing a proper shoes is very important. Look at the shoes of the patient. Educate patient about proper preventive foot care practice such as controlling A1C should be below 7. Daily foot inspection. Sometimes you have a mirror. Old people cannot look at this, they cannot bend. And proper footwear, as I told you. Never walk barefoot, including inside home. Socks are not enough protection. Shoes are essential. Refer patient with active foot ulceration infection to emergency room if severe or to a podiatrist or further evaluation. These are very, very important things. You can prevent it. I hardly get one small ulcer once in 6 months. And the moment I see these symptoms, I start treating. If undetected early, diabetic peripheral neuropathy can lead to neuropathic pain, ulcers, lower limb amputation, and reduced quality of life. And also, it's a burden to the family, society, and country. Often, diabetes peripheral neuropathy is diagnosed as late pre-ulcerative changes, lack of routine systemic screening. Common tools like monofilament testing only detect advanced neuropathy. You must check even before that. Are symptoms? Why early detection? Enables timely intervention, helps prevention of foot ulcer, amputation, reduces overall burden of diabetic complication, enhances the quality of life and patient outcomes. So, how to diagnose? Take a proper history. So, whether the patient has long duration of diabetes, is he old person, metabolic syndrome, obesity, dyslipidemia, tall stature, social determinants of health, and frequently is falling. So, this is important history. Assess the diabetic peripheral neuropathy. Does he have burning, lancinating pain, shooting, worse at night, and hyperalgesia. Sir, I feel my feet is very sensitive. If yes, test for neuropathy, reduced or absent pinprick, or reduced or absent cold temperature. If signs of large fiber, so small fiber and large fiber, the small fiber symptoms are here into, and so below that is large fiber. If he has small fiber, test those. If it's large fiber, reduce or absent vibration sense, reduce absent light touch sensation, reduce ankle jerk. These are all the symptoms and signs of large fiber diabetic peripheral neuropathy. If symptoms and signs distributed in symmetrical and dependent, stalking and, as I told you, stock and low anesthesia, then refer to neurologist and treat underlying condition, that is diabetes. So when you see that, don't think all peripheral neuropathy is due to diabetes. It can be thyroid, like hypothyroid, renal failure, or systemic disease like vasculitis, paraproteinemia, amyloidosis of the nerves, infectious disease like HIV, hepatitis B, Lyme's disease. Lyme's is a very rare disease, less common in India. Inflammatory diseases, demyelinating disease, polyradiculopathy. These are all better treated by neurologists. Nutrition, B12 deficiency, you can check B12, paradoxin, thiamine, and give if they have tocopherol deficiency. Industrial agents, today a lot of them have combined B12 plus vitamin D, B1, B6, B12, vitamin D. Industrial agents like acrylamide and organophosphorus agents can also cause neuropathy. Drugs can cause alcohol, amiodarone, chemotherapy. Most of the patients chemotherapy develop. First thing is ask them to stop alcohol if they have neuropathy. Ask them to stop smoking first, because peripheral neuropathy is more common in those who smoke and also those who take alcohol regularly. Heavy metals like mercury, arsenic can also cause. Lastly, genetic or hereditary factors. So key strategy to reduce neuropathies: achieving glycemic control, prevent diabetes, recommended several guidelines. DCCT EDIC. EDIC is an extended study of DCT. DC stopped after 9.5 years because results were good, but they continued that extended. DCCT was EDIC studies demonstrated glycemic control is strongly linked to diabetic neuropathy in people with type 1. Intensive control of that reduced neuropathy in those patients at 5 years. AD interprets UKPDS findings, that is in type 2 diabetics. Glycemic control prevents retinopathy, nephropathy, possibly neuropathy also. As I told you, 43 years insulin, no nephropathy at all. No neuropathy. ACCORD trial demonstrated intensive glycemic management did not reduce the risk of diabetic neuropathy in people with type 2, but delayed onset. As I told you, to a great extent, metabolic control, but still 20-30% you cannot, because long-term of diabetes more likely to get neuropathy. Important today, tight glycemic control is the only strategy convincingly shown to prevent or delay the development neuropathy in type 1 and to slow down progress of neuropathy in some type 2 diabetes. According to high quality evidence, enhanced glucose control significantly prevent development of clinical neuropathy, reduces nerve conduction vibration threshold in type 1. Type 2 diabetes, enhanced glucose control, reduce incidence of clinical neuropathy. Now, these are all the one way say active prevention, good glycemic control, both type 1 and type 2. Type 1 very effective. As I told you, 43 years no neuropathy. Whereas type 2, there are other factors which also lead to that. Lifestyle modification. Again, if you see mechanism of drugs and what are the drugs? Neuroprotective agents, methylcobalamin. Just giving without any test is useless. Check B12 level. If it is low, give methylcobalamin. Empirical treatment is not going to help. Daily injection, weekly injection. Antioxidants, alpha lipoic acid also has some role to play. Then most important, aldose reductase inhibitors, rapiristat or prostaglandin E1 and acetyl L-carnitine. Most important pharmacological one, apart from these things, are anticonvulsants. Then you have got duloxetine and then venlafaxine and sodium channel blockers and tricyclic amycretin. You can use them initially or in combination also. Most of them, whether amitriptyline, non-triptyline, are very useful. Carbamazepine or oxycarbamazepine, very useful. And most important is anticonvulsant. Gabapentin is given up to maximum 300 milligram, 3 divided doses. Pregabalin is easier. You can give 75 to 300. In India, we don't cross 150 because when you reach 300, they get giddiness, severe sleepiness, and all. I find the best drug is pregabalin, gabapentin. Next combination I use amitriptyline or nortriptyline. If they don't work, you do duloxetine. If you look at pharmacology, that combining pregabalin and duloxetine is not a very good combination. Carbamazepine also helps in some. If they don't help, then you have to do first line and second line of therapy, felbamate and topiramate and others, capsaicin and local patches also add. So you can use one drug, not helpful, two drug, local application also has. There are some non-pharmacological, I have no experience, acupuncture, but definitely, if you send them to a pain clinic, when everything fails, spinal cord stimulation, transcutaneous electrical nerve stimulation, as a last resort, lot of pain clinic have a nerve block. It is so severe, nothing helps. They are desperate to commit suicide, then nerve blocking is there. Of course, these are the new advanced therapies, stem cell therapies, and gene therapies, microbiota therapies, and of course, diet. I don't know, ketogenic diet and all how far useful. We don't have all of them today. Of course, there are some new biomarkers like oxidative stress, SOD, ROS, and methyl and of course, you have interleukin 1 RA and NRR, and also non-coding RNA, MIR14, 146A, non-rat 0 to 1972. Neurological damage can be seen by NACP and H. Our neurologist Sadanand is going to enlighten you on that. I was a part of this 3 year real world study of 6,234 Indian type 2 diabetics, 25 to 60, 3 years duration. And we see that macrovascular complication 3%, 3%, 3.3%, microvascular 18%. Important thing is most common microvascular complication was neuropathy, 82% of microvascular cases. Look at all these neuropathy 82%, nephropathy 20%, retinopathy 40. Meaning, as I told you in the beginning, 80% of these patients, 6,234 Indian patients, had neuropathy. Meaning that neuropathy is probably more common in Indians. Probably it may be genetic hereditary, but more important because 65% of Indian patients do not achieve the target A1C. When to refer to the specialist? Electrophysiological testing, referral to neurologist is rarely needed for screening, except in situation where clinical features are atypical. Neurologist will diagnose maybe other causes of neuropathy. Diagnosis is clear or different details, not for screening, not for treating everybody. I think this is not diabetic neuropathy. We have many patients within 3 months, 6 months, they get severe. Refer to neurologist, or it may be some autoimmune cause. Atypical features of them include motor greater than sensory. If the sensory is predominant, bilateral, symmetrical, it is diabetic peripheral neuropathy. Please remember, bilateral, symmetrical, sensory neuropathy is diabetic. Unilateral, motor more than sensory, it may be non-diabetic, refer to neurologist. Rapid onset, asymmetrical presentation, rapid progression. Please refer to neurologist. Rapidly progressive symptoms, signs of neuropathy may have non-diabetic cause of neuropathy that may require more careful evaluation, referral to the neurologist. Most important, lastly, according to ADA, people with diabetes should have complete foot examination annually. I suggest every visit. I call patient 3 months to 4 months, every visit I examine the foot. Visual examination, the feet at each visit, every 3 to 4 months, as I told. Please look at between toes for any fungal infection, not just neuropathy. Patient must be educated on monitoring blood sugar. Everybody should have glucose meter, self-examination, feed daily, look at ulcer. Somebody is old, he cannot. Ask children to look at their foot. And wounds and broken skin, very important. Let them not cut their nails with a blade. and ask them to go to podiatrist. Every patient of mine, when they come 3 months, ask them go to podiatrist. When I see at the foot, the nails are so bad, they cannot cut it at home. They will injure that. Neuropathy plus injury is a deadly combination. They should also follow diet plan, take medication as advised. Lot of studies have shown high protein diet and diet rich in vitamin B12 can reduce the neuropathy. Ask them to stop smoking. Ask them to stop alcohol 3 months. You will see that neuropathy improves. Stop smoking, stop alcohol. Very important thing, lifestyle modification. Clinicians should make patients aware of contributing role of alcohol, smoking, peripheral neuropathy. Don't ask them to reduce. Somebody asks them to reduce, will never do. Tell them stop smoking. Even 1 cigarette per day is poison. All people who diet should have dietary consult, receive education on what food they should eat, what to avoid. The patient should also enter rehab program and exercise. Regular exercise, losing weight makes it easier to control blood sugar, lower blood pressure, lipids. Podiatric consult is vital as protection of the foot is necessary. If you have a diabetic clinic, you should have a podiatrist. I have a nurse podiatrist doing Doppler studies, biostoichiometry, educating patient, cutting the nails, asking them every visit. I tell them, please use a moisturizer cream. And there are foot creams, moisturizing cream should be applied above and also below the foot. Every night, ask them. By doing that, what happens? Skin becomes smooth. There is no itching, so they won't scratch. Injury will not occur. And especially if you have neuropathy, they will not realize the pain. Itching is there, they scratch in the night, and that causes a wound. All people with diabetes should be informed about avoiding trauma, undergoing any invasive procedure on the feet without prior clearance from diabetologist, endocrinologist, or physician. Patients should be told to avoid cold or hot temperature. Many times, so I have pain. Let me put my feet in hot water, cold water. Very dangerous. Never keep your foot in hot or cold water. This treatment, what lot of people, heart fermentation, hot water therapy, keeping foot in cold water, hot water will cause more damage because they cannot feel the sensation and it will have frostbite or they may have even the burn also. Nurse proficient in diabetes management should educate patient about all aspects of diabetes, importance of euglycemia. Patients should be taught how to monitor blood sugar, as I said, glucose meter. And those who develop neuropathy tend to also have nephropathy, retinopathy. Hence, all people should with neuropathy should be referred to nephrologist, ophthalmologist, or at least do screening. Today, have non-mydriatic camera. You can do urine microalbuminuria. You can also see albumin creatinine ratio. Earliest nephropathy you can detect. There should be open communication between interprofessional team so that all patients are provided with available standard care. When I see that pulses are less, I call my vascular surgeon referring. If I see a wound, I refer to plastic surgeon. I refer this patient to podiatrist. I refer my patient to neurologist. I have something, I am not happy. Can you see my patient? Foot and nail care nurses monitor patients, provide education, inform the team of the patient care. These are all what ADA says. These are the symptoms. You can put it on your clinic as something like a screenshot or a standing. Patient looks, doctor, I've seen this. These symptoms are there. What do you think I should do? So that is why put such things. And this is what a foot examination every visit. If you put these things, previous one, lower one as a stand in your clinic, your healthcare provider should check for these things. Keep your feet healthy at home, healthy diet, moisturizer, inspect feet daily, never walk barefoot, wear proper shoes, inspect shoes inside. Do not use Karens. What is it? Karen cap and all that people use. And also these are the wart removal. So these are the things which are very, very important. Do not show. What are the do's? What are the don'ts? Don't smoke. All these are there. If you keep such standees or even a sticker in your clinic, people sitting will see that this can prevent lot of diabetic neuropathy, which will not probably avoid foot ulcer and amputation. Thank you for your attention. If there are any questions, please put your questions in the drop box and we will try to answer at the end. And Dr. Sadanande will take over and he will talk to you about the further management by neuropathy. And stopping. Yes, I have stopped shaking. Over to Dr. Sadanande. Dr. Anuja.
Yeah. Thank you, sir. So thank you for excellent presentation. Also, you have covered most of the parts of diabetic neuropathy and its management. So I am also going to talk about management, how a neurologist sees. So without wasting much time, like I would like to share my presentation. Let me know if you can see my slides.
Yes,
sir,
we can. Full screen. Thank you. Now we can see very clearly, Dr. Sadan.
At first, I would also like to thank MacLeod and DocMoc Technology for bringing us this platform where we are a diabetologist as well as a neurologist can share the thoughts about diabetic neuropathy. So, uh, uh, without wasting much time, I will just start. So this is my table of content. So we'll discuss about diagnostic and awareness gap in neuropathy. What are the differential diagnoses? Where like you have to think beyond diabetic neuropathy. What are the common causes and what are the consequences of misdiagnosis? And not all neuropathies in diabetic are diabetic neuropathy. So diabetic per se doesn't mean that patient comes to you with only with a diabetic neuropathy. What are the diagnostic pitfalls? What may be the red flag signs where you have to consider that these patients have other causes of neuropathy? Bridging the patient awareness gap in neuropathy symptoms, different diagnostic tools, both clinical and investigative approaches, current and emerging treatment approaches for neuropathy, and at last, clinical pulse recognizing non-diabetic neuropathy in clinical practice. So we know that diabetic neuropathy is a common complication of diabetes with serious individual and socioeconomic consequences. And by far, the distal symmetrical polyneuropathy is the commonest, and apart from cardiovascular autonomic neuropathy. So clinically, distal symmetrical peripheral neuropathy or polyneuropathy affects around 20 to 30% of people with both type 1 and type 2 diabetes. And about 15% of diabetic patients suffer from painful distal symmetrical polyneuropathy. So as Dr. Prasanna also discussed, so classical presentation is distal symmetrical. So apart from that, yes, there may be a atypical presentation of diabetes itself, but whenever there is a atypical presentation, you have to think of other causes also. And once you rules out everything, then still you have to consider the yes, diabetic may be the reason. And the longer duration of diabetes is a major risk factor for this distal symmetrical polyneuropathy and painful polyneuropathy. So this distal symmetrical polyneuropathy incidents are higher in type 2 diabetes than in type 1. So we already discussed like higher in type 2 than type 1, and India faces a significant burden of diabetes related complication, including both microvascular and macrovascular. Some of the reasons may be because of the lack of awareness. Sometimes they stop medicines. Sometimes like when the diabetes is controlled, they reduce the medicine by themselves. So there are many reasons, because most of the time because of the lack of awareness, diabetes is poorly controlled, and so are the complications, both micro and macrovascular. So diabetic peripheral neuropathy prevalent, if you see, it affects from 18% to up to 62% of individual with diabetes in India in different studies. That's why early detection of diabetic peripheral neuropathy is crucial for reducing associated complication. Otherwise, if these symptoms persist, because initially most of the time symptoms are mild, so many times patients ignore them, and even physicians sometimes ignore them. If a diabetic patient comes to you with a just because initial symptoms are just mild numbness, paresthesia. So later on, they come with sometimes if there is a painful component, then it's a bit easy because they come to you early. Otherwise, if it's only tingling and numbness and sometimes negative symptoms, they come to you very late. So implementing screening services at primary healthcare facilities can play a vital role in achieving early diagnosis and improving health outcomes for individuals with diabetes, because in rural area, many times they take medicine from primary health center. So if we have a simple screening tool where we can at least say that, yes, you have like affection of nerve or not, that can also help so that they can come to a specialist physician or neurologist. So we know that despite its major impact on morbidity and mortality, diabetic peripheral neuropathy is frequently underdiagnosed, as we discussed, and underestimated also. Many times physicians and patients also underestimate the consequences. So what can be the side effects later if we don't treat it properly initially? And the factors considered responsible for the challenges in recognition, a timely diagnosis of diabetic peripheral neuropathy include non-specific symptom. As I said, initially there might be only a numbness in the feet, and sometimes symptoms, non-specific symptoms may be mimic other diseases also, leading to delayed diagnosis. Because there is no consensus on optimal screening and diagnosis. That is another reason. Lack of standardized diagnostic protocol is also an important factor. And as we discussed, low physician awareness and poor guideline adherence again as a big problem. So sometimes like insufficient physician awareness regarding diabetic peripheral neuropathy, even when the neuropathy is symptomatic, is a problem. The population-based studies reported that painful diabetic peripheral neuropathy and painless diabetic peripheral neuropathy were previously underdiagnosed in almost 60% and 80% of the diabetic patients. So you can understand that there is a huge treatment gap, particularly in a patient with diabetic peripheral neuropathy. Yes, if it is a painful, they come to you early, so you start treatment early. But if that is a painless, and sometimes if they come to you with negative symptoms, many a times physicians ignore. So multiple visits to different clinicians who have no specialist training to assess the level of risk, to provide advice, or to appropriately refer the patient for further investigation may be the reason for this awareness gap. So yes, there is no gold standard text exists for. There are multiple tests for early diabetic peripheral neuropathy detection, and clinical diagnosis also varies widely between physicians. So that may be another challenges in clinical practice. And bedside sensory tests are usually operator dependent, often detect late stage diabetic peripheral neuropathy, and are challenging to use in busy clinics due to time constraints. So many a times, due to lack of time, you don't examine the patient properly, you don't have much time to see like vibration sense or whether there is a graded sensory loss or not. So sometimes you miss to see the jars. So there are simple clinical tests also that can give you an idea that this patient have diabetes neuropathy. So many times people, because of the lack of time, like ignore these symptoms and ignore the examination, so the diagnosis is delayed. So delayed diagnosis due to low awareness, often by up to 5 years. So you can understand that at least someone comes to you with a mild symptoms, and when they are like we start treatment, it may be up to 5 years delayed. So mild symptoms are because mostly underreported and only severe ones are reported. That may be the reason. And physicians often focus on other complication more with higher morbidity, like renal complication, vascular complication, sometimes retinal complication or ophthalmological complication like that. But they often ignore neuropathic symptoms, because many times patients present with a mild symptoms, and sometimes patients also don't give much emphasis on those symptoms. They say yes, they sometimes can feel tingling and numbness. Sometimes there is a burning sensation, but sometimes it goes away like that. So that's why physicians also ignore the symptoms. So limited diagnostic tool, we already discussed, and underutilized screening methods also is a big reason, and particularly there is lack of any neuropathic screening device or tool, particularly in primary healthcare, where many rural patients go for their medication is another important awareness gap in neuropathy. And obviously, this peripheral neuropathy diagnosis is a little bit time consuming and complex with limited treatment benefits. That may be the challenges for healthcare physician. So now coming to what may be the other differential diagnosis where you have to think beyond diabetic neuropathy. So you have to understand that up to 50% of individuals with diabetes may have other contributing causes of peripheral neuropathy, sometimes even more than one. So common additional causes may be neurotoxic medication, renal disease, CIDP, which we call chronic inflammatory demyelinating neuropathy, and inherited neuropathy. So many a times, if you take careful history, you can usually differentiate between these causes. Like for example, for diabetes, most of the time it's distal symmetrical ascending neuropathy. So most of the time symptoms are more sensory than motor. So if you get a patient had little sensory symptoms but more motor symptoms, if a patient had atypical presentation, like patient presented to you with a single limb or one limb involvement only, if they present to you with a sudden like after tingling numbness, foot drop, if they have severe weakness which despite having controlled diabetes, and if they have short duration diabetes like 1 or 2 years, and they can present to you with a profound symptoms, so then again you have to consider that yes, that may be the due to other causes of neuropathy. So whenever you a patient comes to you, and if there is a atypical features, if any red flag sign, then you have to consider and take history, like whether they are taking any neurotoxic drug or not, whether they have symptoms corroborating with CIDP, whether they have family history of similar disease or not. So because in many a times we have seen that inherited neuropathies also present patient present very late, like even after 10 years, 12 hours after symptom onset, because in inherited neuropathies, initially they present to you with the negative symptoms, only mild numbness sometimes, and then they present to you with a more motor symptoms than sensory symptoms. So if a patient present to you where he has been diagnosed with diabetes like 1 or 2 years back, but when you examine, they said like they have these symptoms for long duration, but recently progressed or worsened, then you have to consider that probably this patient had some inherited neuropathy, particularly if they have family history, and probably it may happen that diabetes on the top of that worsened that neuropathy. So sometimes double etiology may exist, particularly in inherited neuropathy. If a patient has diabetes, so if it is a poorly controlled, their neuropathy worsens very rapidly. Otherwise, these inherited neuropathies are very insidious onset and gradually progressive. Similarly, like if a patient had diabetes, and like there is, if you see sudden worsening despite good control, you have to consider also CIDP if there is a motor symptoms are more than sensory symptom despite diabetes control. Other than that, if a patient has history of alcohol, if they are consuming alcohol, then you have to consider alcohol associated neuropathy on the top of maybe diabetic neuropathy. Similarly, nutrient linked neuropathy like vitamin B12 deficiency related neuropathy. Sometimes, because in a diabetic patient, if they are taking metformin for long duration, there might have a vitamin B12 deficiency. Similarly, in vegetarian, we have seen that particularly there is a vitamin B12 deficiency. So other than vitamin B12 deficiency, there are other vitamin deficiency or nutrient deficiency which can lead to neuropathy. CKD patients also, you have to consider that if they have like prolonged raised urea, they can lead to uremic neuropathy. Vasculitic link neuropathy is another, where apart from like sensory or motor symptoms, they present to you with like sometimes rash, joint pain, and sudden worsening of neuropathy. Sometimes they present to you with a mononeuritis multiplex like presentation, and sometimes they like come to you with a one time like wrist drop, then again on another leg they have foot drop like that. Apart from that, you have to consider toxic metal neuropathy. If a patient has like diabetes, who has started on chemotherapy particularly, and they said like earlier they used to have this numbness, but suddenly like this neuropathy worsened and they have like severe sensory symptoms as well as burning, painful symptoms. Otherwise, diabetes is well controlled. Then you have to consider that probably they have chemotherapy induced neuropathy because many chemotherapy are neurotoxic, and on the top of diabetes they can worsen the peripheral neuropathy very rapidly. Apart from that, like you have to consider like thyroid disease also, in systemic disease, other than vasculitis, paraproteinemia and amyloidosis. So paraproteinemia is another important because sometimes multiple myeloma like can present to you with a neuropathy. So we have seen cases where like multiple myeloma present to you with a rapidly progressive neuropathy. So the when you get rapidly progressing neuropathy, then you have to rule out these causes also. So you have to ask, sometimes they might not have any bone symptoms also. Amyloidosis is a rare but can happen, which can lead to peripheral neuropathy. Apart from that, HIV is a common, hepatitis B and Lyme's disease, which we don't see here, can cause neuropathy. In inflammatory, CIDP is the one of the commonest cause. Nutritional, we already discussed like B12, pyridoxine, thiamine, and tocopherol deficiency. Industrial agent like organophosphorus agent, sometimes initially they after hospital admission they have like progressive symptoms of neuropathy. So we have seen like initially when they admitted they have not much symptoms, but later on they have severe. So in particularly organophosphorus poisoning, you can get both lower motor neuron and upper motor neuron signs. So sometimes you have to carefully examine the patient so that you can find both features of neuropathy as well as spinal cord symptoms. Apart from that, if the patient is sometimes taking long standing some drug like amiodarone, Dapsone, this platinum, and these are usually used in chemotherapy, that is maybe the another reason for chemotherapy induced neuropathy. Heavy metals sometimes like arsenic and mercury may be the reason. Hereditary we already discussed, like CIMT is the one of the commonest cause. Apart from that, autonomic neuropathies are also very common, but then they are also common in like diabetic neuropathy. So we already like discussed. Now coming to like what will be the common causes. So what happens in diabetes, like if there is a associated comorbidity also, most of the time they have hypertension, they have dyslipidemia, so they have altered this signal, insulin signaling. So that's why there are some microvascular changes, decreased perfusion, which can lead to nerve ischemia and then further lead to structural and functional alteration of peripheral nerves, which can lead to painless diabetic neuropathy. And if there is a metabolic changes like hyperactivity of several pathways, then there may lead to oxidative stress, inflammation, and mitochondrial dysfunction. This again leads to structural and functional alterations of peripheral nerves. But here, if there is a metabolic changes, you see painful diabetic neuropathy. So risk factor for the development of painful diabetic neuropathy, it may be genotype also, depends on glycemic burden, obesity, and females are more prone to have a painful diabetic neuropathy. Other factor which can be related with painful diabetic neuropathy is methylglyoxal, vitamin D deficiency, and decreased blood flow. So what may be the consequences of misdiagnosis? So early diagnosis of neuropathy is critical for preventing serious limb-threatening condition, because sometimes if there is a severe neuropathy, they are mostly associated with peripheral vascular disease also, which can lead to further like cellulitis. Diabetic foot is a dreaded complication where many times patients require amputation. So these are like they decrease mortality, increase mortality and morbidity in such conditions. So delayed or misdiagnosis can allow neuropathy to progress to an irreversible stage, severely limiting treatment options. So many a times the patient has to lose his feet because of the like severe diabetic foot. So evidence consistently shows that early detection of diabetic peripheral neuropathy significantly reduces the incidence of foot ulcers and the need for amputation, underscoring the importance of timely and accurate diagnosis. Yes, you can say that you cannot reverse like that the changes happen in nerve, but at least you can halt the progression and relieve the symptoms of diabetic neuropathy to patient. So whenever a patient comes to you, so our target should be like you have to prevent the disease progression as well as provide relief from their neuropathic symptoms. So we already discussed like that not all neuropathies in diabetes are diabetic neuropathy, and estimated 10 to 50% of individual with diabetes may have additional potential cause. Sub individuals may have more than one, so dual or sometimes triple pathology. Many patients present with a combination of different types of diabetic neuropathy, and natural history of diabetic neuropathy with additional contributing causes is not fully understood yet. So again, understand that if a patient has long standing diabetes, whatever may be the other causes of a neuropathy, so many times diabetic neuropathies and other neuropathies some coexist. And this patient who have like long standing diabetes, if they present to you with the other causes of peripheral neuropathy, symptoms can worsen rapidly. So therapeutic impact of treating this additional potential cause of peripheral neuropathy still remains unclear. So these are the red flags in diabetic neuropathy. Like you have to find like complex social stressor or social deprivation, comorbid condition, treatment resistance, disruption of social and emotional development trajectory, discrepant level of psychological distress associated with high level of physical disability. So you have to consider many facets about diabetic neuropathy. So how we can improve? So increase patient awareness and use simple screening tools, support nerve health with neurotropic B vitamins. So doctor already discussed before. So optimize therapy for glucose control and neuroprotection, and use a holistic approach including lifestyle and pain management. So Dr. Prasanna has already detailed about like how to do foot examination, how we can put a leaflet so that whenever patient comes to our OPD can see and be aware of their neuropathic symptoms. So education and proactive care definitely improves patient outcomes, because many a times they don't come to you because of lack of awareness, and they consider it as a mild symptoms and they don't require any medication for that. So what are the recommendation for neuropathy screening in high risk patients? Incorporating nutritional assessment for patient on long-term weight management with glucagon like peptide 1 receptor agonist is essential. Maintaining mandatory assessment and ongoing neuropathy evaluation post bariatric surgery, especially for patients lacking adequate follow-up care, is crucial. It is advisable to regularly measure vitamin B level in individual at risk of deficiency in B1, B6, and B12. And most of the time, we have like multiple drugs available with all these combination. And if you think like that they might have deficiency, you check the vitamin B12 level. If it is usually on lower side, you can consider this vitamin B12. So for symptoms, these vitamin supplements help a lot, and particularly in patients who are more risk of developing peripheral neuropathy, you can intermittently give them these vitamins. Regularly measurement of B vitamins level for patients diagnosed with obstructive sleep apnea is important, because they have a chance of developing vitamin B12 or other vitamin deficiency more compared to normal population. Now, what should be the minimal diagnostic criteria for distal symmetrical polyneuropathy? So possible diabetic sensory motor peripheral neuropathy. So signs and symptoms of diabetic neuropathy. Probable is like signs and symptoms of distal symmetrical polyneuropathy, including any two or more of the following. Like if they have neuropathic symptoms, or reduced distal sensation or abnormal ankle reflexes. So any two or more of the following, and if they have signs and symptoms, they have probable. Confirmed, like if they have abnormal, so for confirmation, you have to do nerve conduction study. So their abnormal nerve conduction studies and abnormal validated measure of a small fiber neuropathy with class 1 evidence, for example, from skin biopsy samples or thermal threshold testing and symptom and signs of distal symmetrical polyneuropathy. So you have to remember that particularly if a patient has only a pure small fiber neuropathy, so for these patients, you might not get anything in nerve conduction studies initially. Sometimes in EMG, you might get some changes of neurogenic pattern or some neuropathic changes, but it may happen that in initial phases in a small fiber neuropathy, you might miss anything, like you might not get anything in nerve conduction study as well as EMG study. So particularly with a small fiber neuropathy, again, it's like sometimes difficult to treat because they sometimes don't respond to usual medication we use, like pregabalin, gabapentin, duloxetine. To sometimes we have to use other less commonly used drug like carbamazepine, particularly for this small fiber neuropathy. So how we can call it subclinical diabetic polydistal symmetrical polyneuropathy, where there is no sign or symptoms with confirmed abnormal conduction studies or validated measure of small fiber neuropathy with class 1 evidence. So that is important. Like if a patient comes to you and routinely you have done a normal nerve conduction study, which we sometimes do if a patient has prolonged history of diabetes. So even if they have not like a profound symptoms or signs of, so if you get abnormal nerve conduction study, means that they have subclinical diabetic peripheral neuropathy. So now coming to clinical and investigative approach for primary care clinician, history with symptoms assessment, neurological examination, including at least ankle reflexes and the sensory examination, whether they have graded sensory loss or not. For pain specialists, neurologists, and for research, like they can do quantitative sensory testing, neurography, EMG, nerve or skin biopsy, and rarely surgical exploration. So we hardly require a nerve biopsy for diagnosing a diabetic distal symmetrical if they have classical symptoms. We require a nerve or skin biopsy if they have atypical presentation where you are not sure whether you are dealing with the diabetic neuropathy or something else. Then sometimes we require this nerve or skin biopsy. So these are the different sensory modality, like for vibration, the responsible fiber is alpha, a beta instrument we use 120 hertz tuning for. So for pain, like a small fiber, C fibers, so here instrument we use neurotapes. For pressure, a beta and a alpha, and you for this you require monofilaments. For light touch, you just require a wisp of cotton, and the A beta and A alpha fibers are responsible for similarly for cold you will need cold tuning for, but I think we don't have much colder, we don't use, so with normal temperature. So for cold, yes, if you do careful examination, then you can get an idea. And ideally, if you have like you have, then you can use cold tuning fork. But for practical purposes, we don't use much. We use mostly sometimes monofilament. Wisp of cotton is easily available, and 120 hertz tuning fork is very helpful, particularly if you have to see the vibration sense. So now coming to current and emerging treatment approaches for neuropathy. So like first is like already Dr. Prasanna discussed like anticonvulsant, particularly pregabalin, gabapentin. These are the established, they have established role. Apart from that, SNRIs, topical analgesic, tricyclic antidepressant, sometimes opioid and IV medication can be used. Apart from that, non-pharmacological food care, already Dr. Prasanna has detailed about that. Lifestyle modification is another important and novel therapy. We ALA, vitamin B12, VLC, we frequently use that. And apart from non-pharmacological, like you can use spinal cord stimulation, TENS, FRAMES, PENS, and NMES. So you have like multiple other modalities also. If you go to a pain clinic, usually they use this different kind of, like they frequently use TENS. So apart from TENS, in some centers you can get the spinal cord stimulation also. And like particularly this frequency modulated electromagnetic neural stimulation, some centers use, but I'm not seeing in many centers. And yes, neuromuscular electric stimulation, some centers use. So these are the different non-pharmacological pain modalities apart from the different drugs which we now use sometimes in combination, like pregabalin plus duloxetine or nortriptyline, or gabapentin plus nortriptyline, or with duloxetine. So different combination. Apart from that, we sometimes use carbamazepine or oxcarbazepine also. And sometimes in refractory cases, we have used lamotrigine also. But it is not useful in every cases. In some cases, it gives you some relief where the patient is not improving with typical agents what we use in clinical practice. So this is the treatment algorithm for painful. So if a patient present to you with a painful diabetic neuropathy, depending on contraindication and comorbidities, so use pregabalin, gabapentin, tricyclic antidepressant, or SNRIs like duloxetine. If pain is inadequately controlled and depending on contraindication, like if they have no contraindication for using this drug, particularly in elderly, you have to be careful about using tricyclic antidepressant and pregabalin, because high dose this pregabalin and tricyclic antidepressant in elderly can lead to drowsiness. Sometimes it can aggravate prosthetic symptoms, can lead to anticholinergic side effects, dry mouth, and so sometimes this symptom may be very bothering and you have to stop. So whenever you use this drug alone or in combination, you have to find out that whether there is any contraindication for the same or not. If not, you can use this. So if pain, like despite using all this like tricyclic antidepressant, this pregabalin, gabapentin, SNRI like duloxetine, then you can use opioid agonist as monotherapy followed by combination therapy if pain control is still inadequate. So these are the like conservative physical therapy, weight bearing exercise, Tai Chi, massage therapy, health optimization of glucose control, managing comorbidities, minimally invasive treatment like TENS and acupuncture, pharmacological treatment. First line is like pregabalin, gabapentin, duloxetine. Second line is venlafaxine, amitriptyline. And third is like opioid group of drug. For interventional, first is spinal cord stimulation. Other than that, you can use other neuromodulation options like first spinal cord stimulation or dorsal root ganglion spinal cord stimulation, like that. Other than that, you can use fentanyl, hydromorphine, or morphine. So these are the like clinical pearls, like how to recognize non-diabetic neuropathy in clinical practice, particularly if they have history of diabetes. You can see here this graph carefully. So these are the major, like you can, if you want to hear a mnemonic, like you can use like mini, like it may be metabolic, immune, neoplastic, or infectious. So you can see here motor or sensory symptoms in hereditary, inherited cause. So, and even you are assessing a neuropathy, particularly whether it is a diabetic or non-diabetic. These are the question. So what are the symptoms? Where are the symptoms? When the symptoms started? What is the duration of the symptoms? What is the setting of the symptoms? Setting means like you have to find out like whether this patient has any family history of similar disease or not. whether these have associated food deformities or not. And if a patient comes to you with like symptoms as well as foot ulcer, then you have to think carefully, like whether they have like if they have longer standing symptoms, and if they are complete sensory loss, whether you are dealing with Hansen's disease or not. Similarly, symptoms of vasculitic or systemic illness. So whether there's a patient had rash, joint pain, headache, features of conjunctivitis, recurrent uveitis, like that. If they have weight loss associated, of they have intermittent fever. So similarly, if you have, whether they have history of cancer or not, whether you are missing paraproteinemia, so whether they have other than neuropathy, they have other symptoms like bone symptoms or renal symptoms or not. So differential diagnosis usually, as we say, inherited CIMT is like common. Metabolic, diabetic, uremic, alcohol, non-vasculitis is like GBS, CIDP, multifocal motor neuropathy, sarcoid, Sjogren's, vasculitis. There are multiple like PAN, Wegener's, Krug-Strock, SLE. So all have like adequate blood test available. If you suspect, you can send this blood test and can get an idea. Paraneoplastic also, like monoclonal gammopathy is the commonest. And for infectious like B, C, Lyme, HIV, we don't see Lyme here. Syphilis is also very, very rare. I have not seen syphilis cases in last 10 years. But yes, earlier while in our internship days, we used to see. Leprosy is also very less common now, but still we see. So these are the like hereditary causes, like we already discussed, like how the symptom started. Here also, say with DSPN is the predominant phenotype, but distribution can vary. And CMT is the most common cause. So associated deformity is important, like Pescavus, claw toes, stork legs, and CMT can occur via de novo mutation. Therefore, a family history might be lacking sometimes. Immune mediated, like GBS, CIDP, we already discussed. Like usually GBS have very characteristic features. I'm not going into detail, and because GBS usually they present to you within like week, because they have rapidly onset motor symptoms. Other than that, like we already discussed about this, like diabetes, sarcoidosis, vasculitic and connective tissue disorder, and they can like present to you with like asymmetric neuropathy, proximal involvement, polyradiculopathy. So they have a multiple presentation. So this is again is a very good picture. You can see here like what are the like different symptoms, how you can see like if they have motor polyneuropathy, if they have sensory motor polyneuropathy, that usually they present to you with a weakness, dimness reflexes. They have like proximal as well as distal weaknesses. If they have sensory neuropathy where the small fiber is, so they have present to you with superficial pain. Similarly, if they have mononeuropathy, which is uncommon compared to other types, they may present to you with the isolated neuropathy also, like third nerve palsy, fourth, sixth, or truncal nerves. Autonomic neuropathy is also very common in diabetes patient. Like here are like hypoglycemic unawareness, hyperhidrosis is the maybe a symptom, sometimes presenting with a bladder dysfunction, postural hypotension, erectile dysfunction, like that. So these are like different complication, like cranial nerve, erectile dysfunction, diabetic foot, urine dysfunction, orthostatic hypotension, and gastrointestinal dysfunction. So management screening for neurologist is always we go with nerve conduction studies, control your sugar, blood pressure, stop alcohol, stop smoking, and report early, like whether they have like a start with a drug which can provide the symptomatic relief. Thank you. So we are now open for discussion.
So thank you so very much, sir. Thank you so very much, Dr. Prasanna Kumar, sir, and Dr. Siddhanand, sir, for your incredibly insightful presentations and for your discussions. So I believe you brought rich complementary perspectives, shedding light on the complexity and importance of early recognition as well as management of diabetic neuropathy. So now I think with your permission, sir, we'd like to open the floor for questions. So to our esteemed colleagues, we would like to just request you all to drop in your questions in the chat box, and we'll be taking it now for the esteemed speakers. So, sir, we have few questions with us. I'll just take one for you, right? So, Dr. Prasanna Kumar, sir, would you want to take the first question?
Yeah. Tell.
So the very first question is from Dr. Anand. He asks, what are some early signs of diabetic neuropathy that should not be missed by the treating physician?
It's a very good question. What are the signs, not symptoms? So, what are the signs that you see diabetic neuropathy? When you examine the patient, probably one of the earliest is loss of vibrations. Dr. Sadanand has already told you small fiber, large fiber. There may be large fiber signs, small fiber signs also. Earliest you see loss of vibrations, then loss of touch. And if you examine the touch, you will see that. The last you will see the painful one which is gone. Why it is that our temperature between the two or four, whatever you have, touch, vibration, pain, right? And these are the things why one of them is variantly depends upon which nerve is a small fiber is affected, large fiber is affected. That's how Sadanand can tell reasons why which sensation is lost first and which one is the last one to say and why in that situation.
Yeah,
Sadanand,
so
sir, would you want to
usually,
add on? Okay.
yeah.
Surely,
Yeah.
sure, sir. Yeah.
So usually what we see in diabetic neuropathy, because these are diabetic neuropathies are length dependent neuropathy. So that's why like initially we mostly see a large fiber and then last to go is small fiber. Usually if your small fiber is involved, usually most of the time they present with a pain. And the detection of a small fiber in particularly nerve conduction, normal nerve conduction study is difficult sometimes because what we do in nerve conduction, routine nerve conduction studies, we try to find out whether there is any large fiber involvement or not. So in small fiber neuropathy, in routine testing, NCB testing, you might see that there is a normal nerve conduction studies, but still patient present to you with a like severe burning. Sometimes like they say like there is a like abnormal and they cannot even touch their feet because of the pain. And when you examine, sometimes jerks are well preserved, power is well like preserved, JPS is also good, and like vibration cells is also present. So I think treating a small fiber neuropathy, I in our clinical practice we see is more difficult compared to large fiber, because mostly large fiber neuropathy, they are easy to pick up. They have like reduced ankle reflexes, they have impaired JPS, impaired vibration sense, and usually most of the time they are length, because of the length dependent. You can see if you examine minutely, you see the like graded sensory loss. But sometimes in a small fiber neuropathy, they have only distal predominant symptoms. In proximal part, they have nothing, and sometimes like they have severe allodynia. So,
And you,
and as the question asked, like so these are the like patient present to you when you examine, you see JPS. But in diabetic neuropathy, they, I think early symptoms are non-specific numbness. Sometimes tinglings here and there. Sometimes they show in a toe they have tingling numbness. Sometimes in fingertips, particular tips of the like toes, they said like they have sometimes tingling and numbness. So this is the time like you should examine carefully patients, and you have to find like whether they have any associated nutrient deficiency or not. And many a times in these early cases, you don't require pregabalin or gabapentin. You just give them some vitamin supplements like B12, B1, then they respond very well. I think Dr. Prasanna, what is your experience, particularly if a non-specific, they have no pain, mild only, sometimes they tell you like, so I think most of the times just giving a combination of vitamins help a lot.
Agree with you. Most often, whenever there's symptoms, patients are happy if you give an ointment. If you look at ointment, see, gone are the days when they are using capsaicin and all, they are counter-irritant. Whereas today, we have got most of the local applications which contains lidocaine. So when you
Yes.
give the local with lidocaine, I don't want to tell the brand names, patient feels better. Many times, even a moisturizing cream also.
Yes.
Forget lidocaine. So they say, as you said rightly, suppose you give some multivitamin, an ointment, they are happy. Pregabalin, gabapentin, mood elevators, or even anticonvulsant, they are at a later stage. But the
Yes.
question
Agree.
was science. For science, don't even depend upon any of those sophisticated tests.
Yes.
Clinically, what you should not miss, what the question was. If you have a simple 128 hertz, the tuning
Yes.
fork,
That is
if
very
you have
easy.
a touch sensation, you have the hot cold this one, a cotton wool. Okay, even if you have the better this one is fine, but you don't have to need all that sophisticated.
Yes.
These
Yes.
are
We
all
don't require.
bedsides equipment. These are bedside signs which you can make out the touch, vibration, hot or cold. You'll be safe. Ankle reflex, by the time it is lost, it's a severe neuropathy.
Severe. Yeah.
That's what Dr. Sadanan said. Don't wait for that. And even if it's a nerve conduction studies, don't tell you positive, negative. It's a matter. How do you know? And some treatment says zero point 0.1 meter increase per second. It doesn't matter to the patient. What patient wants is relief. Sir, I took this treatment. I can sleep well. I have no pain. That's why a lot of them have this nortriptyline, amitriptyline when combined with others. Problem is whether it's pregabalin, amitriptyline, some people, smallest dose 75, they are not able to walk. They
Yes.
sleep 10 hours. So it's a idiosyncrasy. There are patients who take 150 without any problem. There are patients who take 10 mg of nortriptyline happily sleeping. But there are some who say next day I was so drowsy I drank. So it is you have to start with a small dose, find out how they are. If they are comfortable, they can take months together. They are very happy.
Yeah. Agree with sir.
Yeah, next question.
Thank you so very much, sir, for the response. Dr. Sadanand, sir, would you like to take the question first this time?
Yeah. Yeah.
So the question is, what's your recommended approach for routine neuropathy screening during follow-ups in diabetic patients, and how often should it be done?
So, whenever a patient has diabetic, just as Dr. Prasanna said, simple bedside clinical examination, which will take you just 5 minutes, not more than that. Just patient has to lie down. You have to check like whether they have like impaired joint sensation, vibration sensation, and that doesn't take much time. You can do it like 2-3 minutes. We do it routinely. So just that is the basic, because as we discussed at Dr. Prasanna also, so we don't require those monofilaments, and just a simple, even if you clinic maybe for joint position sense, simple, just move the toes and ask the patients like whether it's going up or down. Simple clinical examination, I think, which will take 2-3 minutes more, apart from your regular checkup, just give you an idea. So what I do in, because most of the time these, when they come to us, they have advanced neuropathic symptoms. Hardly like we get a patient who doesn't have any symptoms. Usually we get more referral cases, or if a patient has already other condition, and by the time they are, when they are telling you other symptoms, by on examination we found out that is a diabetic neuropathy. So we definitely examine a little bit thoroughly, but for initial like clinical physician, they just check these basic signs. Just that is enough. They don't require very like monofilaments or any cold like whatever the mentions like. So just simple cotton, just the sit 120 hertz tuning for, and just clinical examination is enough.
Prasanna, sir, would you like to add on to it?
Nothing. I think he has already told everything because we are almost coming to 9:30.
Sorry, sir. So
Yeah, if
maybe
you
we'll
have,
take one more question, sir, and
yeah,
then we'll end the
Yeah.
session. Right.
Yeah.
So sir, the next question we have is, what are some red flags in neuropathy that might indicate non-diabetic causes, and how do you differentiate them? So I think, Dr. Siddhant, sir, you had already
yeah.
covered it in your slides. So would you like to take the question?
Yeah. So as I said, like in diabetes, the classical presentation is like a distal symmetrical sensory motor polyneuropathy. Any patients who come to you So yes, diabetes sometimes can present with a varied presentation. It can happen present with asymmetrical neuropathy. It can lead to mononeuritis multiplex. But the dictum is like when a patient comes to you with a atypical presentation, you have to think of other causes. Like first rule out other causes, and then obviously you are going to treat neuropathy, because treatment wise it doesn't differ much for neuropathic symptoms, but you have to find out the other causes, like whether these patient have, because it is quite common that if a diabetic patient comes to you, they have already like low grade like diabetic neuropathy. On the top of that, they might have other like neuropathy, and most of the time they coexist. So that's why if a patient present to you with any atypical presentation like asymmetrical neuropathy, if a patient has short duration of diabetes, but you think like symptoms are more profound and it does not fit with the diabetes. Similarly, if they have like only one limb involvement, like mononeuropathy or mononeuritis multiplex. Similarly, if they have motor symptoms more than sensory symptoms, like they don't tell you much, but you see the like there is already a like severe foot drop, but they have not much sensory loss. Then you have, because radiculopathy is another important thing, like because many a times diabetic neuropathies have coexistent lumbosacral radiculopathy, so they may coexist. So I think whenever you see a atypical presentation, you rule out other causes. Other causes are very simple to rule out, like you have to just rule out like whether they are typical history, like whether they are taking any drugs which can do a neuropathy or not, whether they have like any symptoms of paraproteinemia, any features of vasculitis, because most of the time you will find other symptoms also if they have other neuropathy. And just if you don't get and you are not very sure, you just do simple blood test also. That can also give you some idea. What is your opinion, sir?
Yeah, I agree with you. He has already told three salient points. Short duration of diabetes, diabetes is well controlled, unilateral, motor rather than sensory. These are four things which are sufficient to think of non-diabetic neuropathy. Thank you, Dr. Anuja. Thank
Thank you
all
so
these
very
people.
much, sir. Yes, sir. So thank you, Dr. Prasanna Kumar, sir, and Dr. Sudanand, sir, for taking out your time today and sharing your experience and wisdom with us. So again, on behalf of all the team, I thank you all for your presence today, and to all the attendees who have joined us today, and for your active participation. Also, I would like to thank our partner today, DocMo team, Vinay, and your team for the smooth conduction of this meeting. So I believe let's continue the conversation and awareness, screening and multidisciplinary care for diabetic neuropathy, because again, early action can truly change outcomes. So thank you everyone, and we look forward to seeing you on the next session. Stay safe,
Thank
stay
you.
informed.
Good night.
Happy
Have a
weekend.
great weekend. Bye.
Thank you.
You all too,
Good
sir.
night.
Thank you so
Bye.
much.